So what do we in NHS England want to do? Well, first of all, we are a new commissioning organisation. Now, I have personally sat in services year in and year out, like you have, and thought, why have we got services that aren't out there in communities trying to work out how do we get people to feel comfortable and safe about accessing our services, and why do we go on commissioning more and more of the kind of the traditional things that we've always commissioned? What information are people using to commission services? And what, as you rightly said, one of the colleagues down here, what training are people getting to help them actually understand what the needs of communities are? So what we are starting to do, and we got off to a bit of a flying start in the last 65 days, what we're starting to do in NHS England is to look at changing four things. Four things are getting services commissioned that's based on real information about the communities, getting really good leadership training that is about leadership based on competency and on focus on inequalities and equalities. We're looking at how do we actually improve intelligent information. How do we stop staff having to spend so much time entering the enormous volume of data we have to do as clinical staff, and actually get time to care? Get time to understand why we're detaining so many people, get time to understand the causes, and also moving on to get people the training for staff that they need that you talked about. I also want, because one of the things I think we absolutely need is we need people like you to come forward and talk with us and help us co-design things. So this is a generic slide, but frankly, I make no apologies for that. What obviously we're trying to do, and I think one way into addressing the BAME issue is to look at what happens to people with physical health needs as well as mental health needs. Because while we have inequalities in terms of the way our mental health services are applied to people with BAME communities, likewise in terms of people accessing physical health care, preventing dementia, preventing long-term conditions, we actually have the same issues for disadvantaged communities, for kind of communities that find services difficult to access. I think, speaking as a mum and as a health professional, of course we want to focus on prevention. And that's why we have to understand the causes. Why are we in this situation we're in? Because I think if it was that easy, people might have changed years back, and I think we need to get your support with that. Early identification and early intervention. As a doctor, and I make no apologies for that, I'm very, very proud to be a doctor. I was the first doctor from my time, so I felt it was a good thing to do. As a doctor, I know that if you have early intervention, the earlier you identify problems arising and the quicker you put in place treatment, the better the outcome for the person, and quite frankly, the better the cost for the whole system. So the question is, what do we need to do to push that one? What's happening then in primary care? So do people feel comfortable and safe accessing primary care? Our model of primary care in this country it's very high pressure for GPs. It's 10 minutes per consultation, 1,900 people on your caseload. In other countries across the world, they have found ways to actually free up GP time, often from the same bureaucratic things as we have in secondary care, to actually make the consultations with people easier, more empathic, more meaningful. I know that in the last 2 years, we have had disinvestment in services at Tier 1 and Tier 2 and Tier 3 levels. So I've seen, in some parts of the country, real disinvestment in assertive outreach, early intervention services. I've seen disinvestment in substance misuse services that provide treatment. Don't just talk about prevention and promotion, actually provide treatment. In London at the minute, there is a 3-fold increase in the numbers of people being referred for forensic placements for children and young people's adolescent services. Now, we don't understand why that happens unless you know, is it something to do with what's happening in the population, what's happening in primary care, what's being commissioned at much lower levels down the chain. So this new information we've got will start to give us those answers if we can come out to your communities and talk. The use of the Mental Health Act. I remember starting a job in a famous academic place that I trained in. And after I'd been there, I think it was a week as a new consultant, I had the Community Health Council come and see me and say, do you realise that your organisation sections people 13 times the national average? And I kind of sat there absolutely shocked. I had not remotely realised that that was the case. And I think I'm not making any excuse for mental health professionals or mental health trusts, but actually often people just don't understand. They don't see objectively the information that tells them how they benchmark against each other. What we now have for the very, very first time, and we did that prototype in London in collaboration with the Care Quality Commission and others, is we now have, for the very first time ever, we can look at borough by borough, CCG by CCG, Health and Wellbeing Board by Health and Wellbeing Board, what are the rates of detention under the civil sections of the Act and under the what I call criminal justice sections of the Act. And then we can start by talking to people like you in local areas to find out, well, what are the causes? And finally, because I can see the chair is looking at me, training.